Bismillahirrahmanirrahim. First of all, I would like to thank Dr. Meher Fouad for his invitation to give this talk about cross-match. Anti-HLA antibodies, any individual who has experienced sensitizing events such as transfusion, pregnancy, or previous transplant is at risk for developing anti-HLA antibodies. So it is important to detect and identify these antibodies prior to the patient receiving an organ for a transplant or retransplant. Why does sensitization occur? Sensitization occurs because of the HLA polymorphism. The HLA loci are some of the most polymorphic regions of the human gene. Polymorphism is focused around the peptide binding region. Every individual's HLA haplotype allows the presentation of different repertoire of peptides to the T cells. This diagram shows the HLA polymorphism. For example, here we can see in the B locus, we have 1,431 alleles that gives 1,165 proteins on the cell surface. Cross-match test, the purpose of the cross-match test is to detect the presence of preformed antibodies in the recipient that are reactive against the donor tissue. Panel-reactive antibody is a screening mechanism to determine the HLA antibody profile of potential transplant recipient. Periodic screening, this depends on the center, whether monthly or quarterly, of the recipient sera with a panel of HLA type cells. Sensitization of the recipient is expressed as a percentage of serum reactivity with the total panel. Typically, high PRA is indicative of highly sensitized recipient, one who is at risk for early graft loss. The CDC PRA percent is calculated by reacting patient serum against 50 to 100 cells. Cross-matching. Cross-match looks specifically for the presence of preformed antibodies against only the HLA on a potential donor. The cross-match methods are either lymphocytotoxicity or CTC, or the more sensitive technique, the flow cytometry. In the CTC cross-match, the patient serum is incubated with a donor lymphocyte, and then the complement is added, and this, if it is positive, there is killing of the cells, and the lymphocytes cannot exclude the dye, and the cells appear whether red in case of using leucine Y or blue in case of using trypan blue. In the flow cytometry cross-match, also the serum of the patient is incubated with the donor of the lymphocytes, and then a conjugate is added, which is a fluorescinated anti-IgG. And if the cross-match is positive, there is shifting of the fluorescence intensity from negative to positive. Screening of HLA antibodies or PRA, panel-reactive antibody analysis, has a clear application by determining the percentage of panel cells reactive with the patient serum. For example, if 75% of the panel cells are reactive with the patient serum, then on average, this recipient will have a positive cross-match with 3/4 of donors. Highly sensitized recipients are defined as having persistent PRA more than 50%. So if we have a panel and half of this panel is reactive with the patient serum, we can say that the PRA is 50%. So this diagram summarizes the methods for antibody screening. Antibody screening, either antigen non-specific and it is cell-based assay, in which we can use the CDC or the complement-dependent cytotoxicity assay, whether sensitive CDC or modified CDC to increase its sensitivity, and the flow cytometry assay. Other assays which determine the presence of antibodies are the ELISA technique the flow PRA, and the Luminix with single antigens. Modification of CDC. To improve the sensitivity of the CDC, several modifications have been developed. First of all, I can increase the time of incubation to increase the sensitivity, or do a washing step. This washing step has the advantage of removing anti-complementary factors, or by addition of anti-human globulin. So we can see here the steps of the microlymphocyte toxicity test. The first step is the incubation of cells with the serum. We can add a modification by increasing this time, or increasing the time with the rapid complement. We can add a step of washing to remove the anti-complementary factors, or we can add anti-human globulin to increase the sensitivity of the assay. Evaluation of HLA antibody detection. So the first is the cytotoxicity, in which the lymphocytes are incubated with the serum. If there is anti-HLA antibody become attached to the lymphocyte, upon addition of the complement, there is activation, and the membrane attack complex of the complement will result in death of the lymphocytes and introduction of the dye into the lymphocytes. In case of enhanced lymphocyte toxicity, either we increase the time or do washing, or add anti-human globulin. This anti-human globulin increases the sensitivity of the assay. Or by doing flow cytometry, which is the most sensitive technique for the cross-match, in which the lymphocytes attached to the antibodies are attached to the lymphocytes again, and we add the fluorescinated anti-human globulin. If it is positive, there is increase in the intensity of fluorescence. Also, we can differentiate between B lymphocyte cross-match and T lymphocyte cross-match by addition of more monoclonal antibodies like CD19 for B cells or CD3 for T cells. Antibody screening by ELISA method. This assay uses microtiter plates with HLA antigens bound to the flat bottom wells. After addition of the test serum to the wells, the presence of HLA-specific antibody is detected by the addition of an enzyme conjugate antiglobulin and the chromogenic substrate, which result in color change in the wells containing HLA-specific antibody. Antibody screening by ELISA, such assay have multiple advantages over lymphocyte toxicity test, as it has a higher sensitivity, elimination from the need of viable lymphocytes and complement, detection of only HLA-specific antibodies, differentiation between anti-HLA class 1 and class 2, partial automation, increased objectivity when an ELISA plate reader is used. Antibody detection PRA by flow cytometry. Flow cytometric antibody screens utilize purified HLA antigens, which are coated onto the microbeads of 2 to 4 micrometer in diameter. The microbeads are coated with HLA antigens extracted from cell panel of HLA type cell lines. The beads are available with either purified HLA class 1 or class 2 HLA antigens, or a mixture of both. Antibody detection by flow cytometry, as with the ELISA assay, flow screening can also distinguish between IgG and IgM antibodies with the use of either anti-IgG secondary antibody or anti-IgM secondary antibody, detect non-complement fixing antibodies. In addition, flow PRA was found to be more sensitive than ELISA for detecting anti-HLA antibodies. This shows the principle of the two assays. In the ELISA, the wells of the plate are coated with the HLA antigens, to which the patient serum is added, followed by a secondary antibody attached, to which an enzyme is attached, and then a substrate which gives a color in the well. In case of flow cytometry, the beads are coated with the HLA antigens, and if there is positivity, the antibodies will attach to the beads, followed by the conjugate. In this case, it is fluorescein conjugated, and there is an increase in the amount of fluorescence intensity. Antibody detection using Luminix. In Luminix, the antigen-antibody reaction takes place on the surface of microsphere cells that have been color-coded and pre-coated with antigen. Each of these microspheres has a distinctive color code and defined antigens pre-coated on each surface. The microspheres are incubated with this serum to allow the binding of antibody if present to the pre-coated antigens. When the microspheres pass through two lasers, one of the lasers is known as classification laser, reports the microsphere identity according to its color code, whereas the other laser is the reporter laser, which reports the occurrence of anti-antibody reaction. Luminex can run up to 96 samples in a single run and determine the antibody specificities all in one tray, so very time efficient. We have here the microspheres. These microspheres can be coated with either class 1 beads like HLA, AB, and psilocybe, or coated with the class 2 beads like DR, DQ, and TP. The first laser recognizes the bead, tells the instrument which bead is being examined. And this bead is coated with the HLA antigen to which the serum is added, and if there is antibody, it will become attached to this antigen, followed by addition of the conjugate, which is 5-ors conjugated. And second lasers tells the instrument how much antibody is bound to this bead. We have two main kits on the Luminex. The first kit is the lab screen kit, on which the microspheres are coated with all types of the HLA antigen, whether class 1 or 2. And so in this case, we just say if the patient is positive or negative. While the lab screening single antigen, each bead is coated with a single type of HLA antigen. So when it is positive, it means that the patient has antibodies to this specific antigen. So if we again repeat the principle, we have the microsphere to which the HLA antigen is on its surface, followed by addition of the patient's serum. If there is an antibody, it will become attached to the antigen, and the conjugate is 5-ors coated, and the laser too can recognize this. This how the result looks like if it is a screening test. The screening test is for class 1, HLA class 1, HLA class 2, and MIG-A as well. And this is for a single antigen. How it looks, this gives the y-axis gives the intensity of fluorescence, while the x-axis in which different type of antigens are present. It can give you the percentage of PRA positivity as well as the mean intensity of each HLA antigen, positivity for each specific type, and can be used for class 1 and class 2. What's virtual cross-match or donor-specific antibody? Defined as the ability to predict the outcome of the final cross-match based on HLA antibody screening and identification. Comparison of the HLA antibody specificities of the recipient with the HLA typing of the donor. If antibody specificity of the recipient matches one or more of HLA antigens of the donor, then donor-specific antibody is present. Donor-specific antibody is a predictor for development of antibody-mediated rejection and an adverse prognostic indicator for long-term graft survival. For example, here we introduce the recipient antigen, sorry, the donors, we can identify the type of antibodies against the donor antigen by introducing the typing of the donor. In this case, the machine encircles the antibodies which has a positive reaction, and it gives the virtual cross match. Virtual cross match in comparison to the flow cytometry cross match. Virtual cross match and flow cytometry cross match in one of the studies show concordance in 86% of patients, while 14% are disconcordant. Virtual cross match negative and flow cytometry cross match positive was in 7%, and these 7% give excellent function and normal biopsy at 3 and 6 months. While virtual cross match positive and flow cytometry negative, the rest 7%, 25% stop clinical antibody-mediated rejection despite treatment. Why look at MIC? MIC-A antibodies are more frequent in patients with graft failure than in those with functioning graft. MIC-A antibodies may play a role in graft failure even without HLA antibodies. Detection of MIC-A antibodies may be a useful tool in improving transplant outcome. MIC stands for Major Histocompatibility Complex Class 1 chain related. MIC-A is very close to HLA-B locus. MIC-B is less than 130 kilobase from HLA-B, expressed on endothelial cells, epithelial cells, and fibroblasts, not expressed on lymphocytes, can be induced by stress. Single chain protein, polymorphic, 51 protein variant, 59 alleles. So this diagram shows the short arm of chromosome number 6, in which the class 1 HLA antigens are loci present, HLA A, B, and C. MIC-A and MIC-B are near to the HLA-B locus. The MIC-A there is 57 alleles and MIC-B 18 alleles, and it's mainly present on endothelial cells, not lymphocytes. We can see from this diagram there is a decrease in the percent of graft survival if you compare patients having negative MIC-A and patients having positive MIC-A antibodies. Why? Because these antibodies adhere to the endothelium, result in damage of the and endothelial proliferation that finally lead to entomophagus. So we can conclude that solid assays have replaced cell-based assays but become the gold standard for identifying HLA antibodies. Thank you.
Thank you, Professor Dr. Mervat. Let's start by a simple question. You informed us that virtual cross-match positive patient with negative flow cytometry cross-match developed a 25% antibody-mediated rejection despite aggressive induction therapy.
Yes.
This means that it is more important or more sensitive than the traditional use of flow cytometry cross-match. Exactly. Okay, thank you. Further, Dr.
Thank you very much Professor Mervat Ansary. ودايما انا اقول للدكتوره مرفت يا ريت نسكسيد ان احنا نعمل لها كلونينج. Let me ask you about the concept of permissive.
انت بتاع الستيم سيلز يعني.
الدكتوره مرفت يعني هي اللي شغاله كلها في
ايوه ما انت اللي تعمل الكلونينج ده.
هنعمله عندها يا باشا. Would you elaborate on the concept of permissive and non-permissive mismatches؟ يعني ازاي يبقى mismatch permissive يعني يبقى very good results and its influence on the Luminex screening. هل ممكن نعمل نوردر a special form of Luminex virtual cross-match يبقى modified بالpermissive والnon-permissive عشان الvirtual ممكن يبقى مضلل ويبقى عندي permissive antibodies of benefit مش of bad effects. لو التوبيك ده ممكن نعمله محاضره السنه الجايه ممكن لو مش don't want to answer دلوقتي ممكن نخليه توبيك اوف next time اللي هو البرميسيف والنون برميسيف mismatches and the impact on the panel reactive antibody virtual cross match.
هل المقصود بكلمه permissive انها to permit the دي procedure
ده يعني يجيب جود ريزلتس، يعني المس ماتش اللي يدي جود ريزلتس مش باد ريزلتس. كلمه بيرميسيف
انا
يعني
خايف لا يكون معناها حاجه ثانيه.
لا
والله
لا بيرميسيف يعني نتائجه احسن من لما يكون ماتش.
ولا بيرميسيف يعني اهو نمشيه السلام.
لا بيرميسيف يعني نتائجه احسن من اللي يكون ماتش. يعني لما يكون المس ماتش موجود النتائج تبقى احسن.
يعني بروتكتيف انتي بودي.
طب انا عندي
بروتكتيف انتي بودي يعني.
انا عندي سؤال. اللي انا فهمته كده ان السي دي سي كروس ماتش CDC يعني complement dependent cytotoxicity. طب if we have non-complement dependent antibodies. ما الانتيبوديز فيها complement
important is the complement dependent cytotoxicity.
الميكروفون
The most important antibodies are the antibodies that activate the complement.
Yes, but we have now
IgG3 first and then IgG1.
Yes.
Because the IgG2 is less activating and the IgG4 not.
But we know now that there are certain cases of antibodies which are not dependent on the complement.
Yes. It's not detected by the CDC. It's detected by the flow cytometric cross match.
Yes.
Or can be detected by other methods for
solid phase assay.
But the most clinically important is the complement activating antibody. That's why on the Lonex we have also the C1Q. Yes, the C1Q assay in which we can detect on the Luminex the complement activating antibodies. So after doing the PRA, we can differentiate which of these antibodies is complement activating and which of them are non-complement activating.
In the same issue which Professor Yasser mentioned about 25% subclinical antibody-mediated rejection in negative flow cytometry.
Yes.
So if we don't have the virtual cross-matching, we're thinking that we are immune if we do CDC negative and flow negative. 25% is a big number. Despite
no, it's only 25% of the non-concordant cases, so it's a very small number of cases, which is, there is always a concordance between...
So do you have a number if we have a CDC negativity and the flow negative? Yes. Do we have a number how much will be antibody mediated?
25% من 15 يعني 4%.
Without the virtual, it's
about 7%.
يعني حوالي
7%.
قالت ان 15% منهم
and forget about virtual cross match. I'm asking different issue because virtual is not allowed.
7% منهم virtual positive negative.
That's what I'm saying. Virtual.
العكس بقى.
We used to do before CDC and flow cytometry.
يعني 25% من 7%.
Yeah, exactly. So it's a very small percentage, and this to show the importance of the virtual cross-match actually.
My question is, what is the cut-off point of the mean fluorescence intensity to say positive or negative?
It's very some of the studies they say that it's very important if it exceeds 5,000. We can consider it very less important if it is less than 500.
هو دلوقتي
no exact
cut off 1000 دلوقتي بتاعي اكتر منه.
It's a little bit maybe Dr. Marwan can
عندنا شركة شرطين please for the audience